Right, I think we'll kick off. So welcome everyone to our webinar on Demystifying Partnership Working today. Thank you all so much for joining us and making the time to join us. To note, we will be recording this session and we will share it with those who could not join us today. And also in case tech is not on your side today, there will be a recording which we will share with you as well. So don't worry or panic if the network goes a little out of place for you. I'm Sonakshi. I'm a senior researcher at IVAR, which is the Institute for Voluntary Action Research, and I'm delighted to be here to share our learnings and reflections with you all today. I'm joined by my colleagues, Amara and Vanessa. Amara will come in and do housekeeping shortly, and Vanessa is our tech person. So do message Vanessa if you have any tech questions. In terms of the flow of the webinar, I'll share a bit about IVAR and connecting health communities, followed by sharing some learnings and reflections from our report, Not Ticking Boxes, on partnership working. And I'll then hand over to Mabrak from DRI, who will speak, who's our speaker for today. And she's joined by Kay from East Sussex, who will help with the question and answers and share her thoughts as well. They are one of the areas that we worked with through Connecting Health Communities program. And then there will be enough time for some question and answers as well after our presentation. So please start posting your questions in as we start speaking. And once again, thank you so much for joining us today. I'm going to hand over to you, Amara, to do some quick housekeeping.
Thanks, Sonakshi. Good afternoon, everyone. My name is Amara. I use she and her pronouns, and I am one of the researchers at IVAR. I will just be doing some housekeeping and then supporting with the Q&A a little bit later on. All I really have to say is that there are two ways you can communicate with us during this webinar. The first is through the Q&A box, which we're asking that you use to post any questions that you have for our speakers today. And then in the general chat box, if you have any tech queries or anything that you need some support with, please do use that to communicate those as well. We are quite a large group today, which is amazing. We're so happy to see so many of you. In the essence of timekeeping, what we'd like to do is ask you to introduce yourself and your organizations in the chat so that other people can have a read and get to know who's in the room. Back to you, Sonakshi.
Thanks, Amara. I'm just going to quickly share my screen and hopefully you'll be able to see that. Can you see the screen? I can see some nods maybe. Okay. Yeah. So a bit about IVAR before I get into connecting health communities. So we facilitate collaboration and learning with charities, foundations, and public agencies to deliver useful and usable insights that make a difference to communities. We operate at the interface of different sectors, and everything we do is about supporting partnerships to do the best for the communities and the causes that they serve. So at IVAR, we've been supporting partnerships, local partnerships between voluntary sector and the public sectors for around 18 years now. And I've personally been involved in this work since 2018, leading the work. So right from running workshops for cross-sector partners at a very local level through to connecting what we're learning at a local level into the national level conversations like this one, for example. And the latest iteration of is the one that I'm here to talk about today, which is connecting health communities. As the slide shows, we're currently working in Cheshire East, Dudley, St. Helens, Wandsworth, and each of them have a very specific health inequality focus. Our Not Ticking Boxes report has stories from the phase 1 areas, one of whom is here on the call today, East Sussex, and you will hear from quite shortly. So a bit about connecting health communities and what is connecting health communities. We are a very interesting policy context where NHS England recognizes that the voluntary community and social enterprise organizations, or VCSEs for short, play an essential role in local healthcare systems. And there's a clear expectation that VCSE organizations should be involved in both the ICS governance as well as in delivery. However, the NHS also acknowledges significant challenges. Like, for example, there could be as many as 16,000 VCSE organizations in a large ICS. The diversity of the sector is its strength and needs to be recognized and celebrated. But it can be quite daunting for an ICS to engage in a systematic way with the VCSE sector. Similarly, for the VCSE sector to navigate the complex and ever-changing landscape of an ICS and to overcome funding and time constraints. And that is technically the space where Connecting Health Communities initiative occupies. We support voluntary organizations and local systems to work together to engage with complexity and achieve change. I won't go into all of the details of the different areas that we are working with right now, but just to give you a sense of the kind of health inequalities that can be worked in this way, and that includes right from things like access to healthcare in rural North Yorkshire, through to reducing smoking in Sheffield, through to things, through to improving access to cancer screening in Eastbourne, to like increasing take up of TB screening in Crewe, etc. So these are the kind of health inequalities that we're working with, and more details can be found in our reports. Next slide. Sorry. Yeah, so this is our report that tells the story of our 4 areas. And I just wanted to highlight key messages about the role of voluntary sector and why cross-sector partnership working is important. So voluntary sectors need to be involved in the decision-making about services that affect local people, as they hold important intelligence and data about local need. Working in this way ensures that solutions to local challenges are streamlined, and that reduces the risk of duplication or saturation of work towards particular groups. For good partnership working, statutory partners need to recognize the role of VCSE that they play in terms of providing healthcare, well-being, reducing health inequalities, and overall see them as valued partners. Additionally, VCSE partners provide the much needed flexibility in delivering services at times when NHS organizations are required to focus only on delivering essential work. And I'd like to read you a quote from one of the areas that we worked with previously. Value VCSEs, don't consider them as cheap or the ones who need funding all the time. See them as valued partners. Some key messages about demystifying partnership working from our report and our work that I wanted to share with you today is firstly, be clear about your purpose and why you want to work in a cross-sector partnership. It is important to take a step back to think of why you're bringing people together and what you hope to achieve from working in this way. And because everybody has different priorities, it can be hard to narrow down to a particular focus. But from our working in this way, I think it's a very helpful starting point to start off by identifying a key priority and a key focus and being clear about that together as a partnership. Secondly, start somewhere. From our experience, we realize that we go where the energy is. So choose a geography or a community who have a vision for change. Harness that energy and excitement to establish partnerships and this new way of working. Thirdly, and importantly, be ready to test and learn. Working in partnerships can be really messy. So create time to and permission to step back from the day-to-day actions and review how things are going, reflect together, and adapt your approach as you go ahead and work in this way. Fourthly, ask if the right people are involved in the work. We've realized that meaningful buy-in from senior leaders makes a real difference. And particularly having meaningful representation from a range and different partners around the metaphorical decision-making table is really key. And regularly asking and checking in, who do we need to work with, who isn't in the room or around the table, and who needs to be there and who should be there is a question to ask as you're thinking of doing partnership working. Have a dual focus on actions and relationships. Now, when we get into the doing the day-to-day and doing the actions, while that is really important, don't forget to cultivate and maintain the relationships that underpin the joint actions. Collaborative working can be emotionally quite hard, and it is important to recognize this and to create opportunities for people to express their frustrations, to reconnect with the ambition and the overall purpose of working in this way that is driving you to working together. And linked to this is also making sure that you are celebrating along the way, however small the win might look like, but ensuring that you're doing that as well. And sixth and finally, explore with communities what would help sustain collaborations in the long run. I think from our experience, identifying individuals and system leaders who act as collaborative champions is really important. The ones who are front facing, doing the work in the front, but the ones who are in the back end, helping with the strategy are really key as well. And these are the kind of people who have the ability to look beyond just their organizations, spot opportunities for collaboration, and are great at building relationships and bringing people together. One thing that helps from our experience of sustaining partnerships is ensuring that people have time, not just to discuss the work that they're doing, but also on the how are they working together, reflecting on what's working, what's not working, and adapting the process accordingly. So we are an independent research organization, but we are not completely neutral. We believe in the power of the voluntary sector and involving communities in addressing the challenges that affect them. And that is a starting point for our work. And there are two things that I want to end on today before I hand over to our speaker, Mabrak. Our first one, work with local communities, because this leads to better service design and delivery. We often see the temptation to simplify, engagement with communities and the voluntary sector, but this risks missing out on the nuance of why certain issues prevail and on delivering effective solutions. Communities, from our experience, are very well placed to determine if a solution is viable and usable for them. Involving them in action planning means you're really valuing people and their stories and recognizing that they can make the right choices for their own health and well-being. However, they need to be involved in the design of services and given choices based on their need. The second thing that I want to leave you with today is challenge and change the language you're using. Many communities and groups do not like to be labeled as deprived or BAME or socially isolated, and there's often stigma attached to certain health conditions like tuberculosis. Using language that strengthens individuals and is asset-based is important, and you can achieve this through constructive conversations and dialogues with communities and groups who are involved in the work. I will end there, but do ask me more questions, put in the chat or in the question box, or anything that struck you from the conversation today as well. Thank you so much for giving me your time. I'm going to hand over to Mabrak. Mabrak is the founder, director, and facilitator of Diversity Resource International, and we're really privileged to have her at this webinar. Over to you, Mabrak.
Thank you very much. Good afternoon, everybody. I am Mabrak, one of the founder of Diversity Resource International, set up in 2004 in Hastings, and now working across Sussex and beyond. I thank IVR for evolving and keep going with this project, and I'm happy to share the legacy of East Sussex. Next, please.
Yes.
So we start this in Eastbourne in partnership with local organizations in how to navigate UK healthcare, the language and communication, if there are any gaps, and what is involved in clinical procedures, and whether there is a lack of cultural and bilingual sensitivity, and also fear of sharing private symptoms by different people of different languages and cultures. Next, please. So we took the cancer screening as a case study, although it led to many other health issues, but we needed to focus on one, on one case study, which leads us to identify gaps in cultural competency, training for GPs and surgery staff, the use of interpreting and translation, and also a healthy way of direct engagement with communities as a result of the gaps that we found during the 18 months engagement with communities, with NHS health professionals and other voluntary and public sector organizations. Next, please. So as an outcome of this, we concluded that we need to have cross-cultural competency training for public health professionals, and we started with addressing this with GP receptions and a wider health professionals, and that is to learn about importance of effective communication, to identify specific communication barriers that exist in waiting rooms, in how to communicate with those ethnically diverse communities, and then to consider and implement actions to overcome these communication barriers by both the communities, the voluntary sector, and the public health departments and professionals. And also to encourage people to have pledged to improve. One of the main one of the main aim of the training is to have an open conversation and to help each other. Okay, how do we overcome this? What is your pledge, and how do we follow it after we pledged? So we have so far delivered 4 trainings for this, 2 for the PCNs and then 2 for the CBSE organizations in East Sussex. It is still on testing mode, and we're learning a lot from those trainings. Next, please. And also one of the identified gaps is supporting people with language communication support, including BSL and other form of communications. And we need, to know that interpreting and translation service exists, formally contracted by Sussex Commission, Sussex NHS, and also the local authorities commissioned by both of them. The barrier here is that lack of cultural competency, awareness, whether there is a training, in whether there is an interpreting and translation to access the return, or the public professionals might not know. It might be somewhere in their computer, but they don't know how to access it. And sometimes maybe the interpreting agencies might not have the language is required. But also a lack of bilingual and cultural competency by the people who need language support. There is self-confidence, there is fear of asking for communication support. So having those 2 gaps is what kind of prompt us to set up the curiosity in culture, language, but also empower the communities to take a kind of control to challenge those barriers within their communities. Next, please. So what actions did we take out of that finding? And how do we try to fill the gaps that we identified? As a community interest organization, DRI, working with the NHS and other organizations such as Active Sussex, the PCNs, the Sussex Community Foundation, the Lottery Community Fund, we set up a working group for ladies only, mixed gender, men only, and family and groups. As you can see in the picture, it starts with few, but then it becomes more. In particular, with the working group of the ladies from all walks, from all professions, and one thing evolved from that is the information that we share when we go for walks. For example, from that top picture, there are 8 medical doctors and 1 nurse within this group. And you can imagine how much health talk going on within that group. And also with other groups as well. So it's a very a kind of easy, informal to sit kind of language and health information that we exchange with each other. And we create themes for the walks. Sometimes we, just between us, we invite a guest speaker, mental and physical health experts, and different, someone who is keen for exercises and tips on how to look after ourselves, our mental health, and after our well-being. Next, please. Another initiative to break the communication barrier is having an English classes, not just how to write a fantastic letter or grammar or spelling, but just conversational, and how to access with your GP. What do you say when you go to, when you try to ask, a question to your GP? How do you access other health and social care services? How do you join exercise groups and working groups? And also we invite different, school. How do you deal with your child's teacher when the child is not unhappy or is not doing very well? What is the English terms that you could use? So not necessarily a formal English, but a useful language and social skills and interpersonal skills to address the communication barrier is what we do. We do this in Hastings and in St. Leonard's and Peacehaven areas. And it's funded by different organizations. The funding might not be big funding or long term, but it just kick the initiatives, and then we work with other partners to continue what we're doing. Next, please. This is part of community outreach and networking. Because we've been working with those communities, we also go to phase centers, to address how men would access prostate cancer. What is this, the screening, what it is involved. We invite professionals in that area, and they give a very simple and demystified what people believe when you try to access prostate cancer, colon cancer, and so on and so on. So these are all the community outreach work that we go through, and that partnership and collaboration is key into that. Who is supporting this? For example, it might be as little as just covering the transportation barrier for those who wants to walk and to come to the meeting point of the walk. Not everybody need to be reimbursed for that bus or train, but people do. Some people do, and encourage them to say, we're happy to reimburse you for your train, for the train ticket or bus ticket, and we get that from Active Sussex. Yeah, it's all about engaging with the communities. Next, please. And also another thing that we do as well is we record short films in terms of the experience of people who lived in Sussex for 20, 30 years. what is their experience, what's their contributions, how do they overcome challenge, from all walks, from all, areas of, could be race, it could be sexuality, it could be gender, it could be anything. We gather those, and there will be a short film funded by the Lottery Fund and Lewis District Council, and we take that across Sussex for people to see, to encourage, to share information, but also to be proud of being a citizen of Sussex. Next, please. So these are the steps that we took following the IVAR collaborative in terms of cancer awareness activities. We set up working groups, health and well-being workshops. We have 7 informal groups of ethnically diverse carriers, and we go in and give them all this information about cancer screening, and also through the Connecting Health Communities. We have a cultural competency training, as I said before, and through the Universal Health Sketch, which is funded by Sussex NHS, we have all those English and interpersonal skills classes in 2 places. Next, please. So how do we do this? What is the mechanism of engaging with those communities? Well, we have community researchers, trained by DRI with Dr. Ya in 2021, but also with the Sussex Medical School just this year. So we have about 13 community researchers. We have about 53 bilingual advocates. We have interpreters and community outreach workers. So we empower them to reach their own communities. They bring lived experience and understanding of the complexities, and we offer skill development through training and mentorship, ongoing training, ongoing engagement, and including, we working quite closely with the research at the Sussex Medical School to really enhance the skills of those community researchers. They might have degrees and masters. They might not have, doctors or PhDs, but they have a deep understanding and lived experience. And if you can give these shorter trainings and upgrading, then the universities, the research institutions such as, IVR, and I think we work with NHIR as well in the past, and all universities such as Open University are working with us. The UCL is working with us in terms of mental health. So you bring together, and academics, as much as we learn from them, they learn from us as well. And that has to be an action research, because if research is not going to involve the communities, then it would just remain in the shelf. So we encourage the communities to take over. And if the communities say, no, that's not what we need, our priority is this, then we have to be very humble to change that. And that is by working with those universities and research institutions. And it seems like it's working very well on that area. Thank you. Next. Yeah, this is again, bringing communities into to co-develop recommendations and program planning, and that makes the research and the project more targeted and effective. And then we go back and see it again. Has it worked or not work? What worked well and what is not working, that we need to change according to the community's recommendations and needs. Next, please. It's more co-production. We can design the best, but you have to be very humble to reproduction or to make it according to the need. And we get this information by gathering the communities, and it's vice versa. Like I said, questionnaire can come from research institutions, but if the community say that's not how you ask, Then we work with the research institutions to adapt the questionnaire, the way we ask, the way we approach. So we remove barriers, big barriers that we have is budget and time, but we work around it. Next, please. So one of these is that once you empower the communities, they take over. They solve their own problems, but it's not a shortcut. It's a process, and it takes a long time to get to where we are. Probably it takes years. Next, please. So this is if you want to follow, what the RI is doing and how how we work with others, what research that we're doing, and who is involved in this research. Contact us in any way. We can share what we're doing, and I'm sure we'll share this PowerPoint as well. When research is finished and what's the outcome, and how do we engage with the communities, in what area, all those we're happy to share. Thank you. Next. So again, this is the pointers of different activities, the outcome, and where we're going. I think that is it for me, unless I have more slides. Thank you very much.
No, all good. Thanks, Mabrak. Kay, do you want to share any reflections or anything else? Just to introduce you as well, Kay. Kay is a senior partnerships manager at NHS Sussex for East Sussex. Yeah, any other reflections?
Thank you so much. So apologies, I don't have a corporate background as we're on Zoom, and just in case we have other colleagues from NHS here. So it's been a real privilege to be part of this work. Initially, when we started seeing the opportunity to work with IVAR, that was not long after the sort of probably first into second lockdown of COVID, which does seem a long time ago for some of us, but we worked with Health Watch, our colleagues in the local authority, including public health, to get the application together. What you've heard, as Mabrak says, takes time to build, and drawing on from all that expertise and other colleagues working in this field to deliver. Initially, it was really challenging to think, what do we focus on? Because there were so many areas around inequalities and looking at where to pick this out from. And we were very fortunate with Amanda Asayer, who's a PCN, a lighthouse practice manager and business partner there. She was able to identify a big gap in people coming forward for cancer screening. So that gave us the focus that we really needed to sort of say, well, right, okay, let's look around that. And Mabrak, the workshops, we had 3 workshops facilitated by IVAR, and anyone thinking about signing up or working with IVAR as well, this is not a plug that I've been asked to do, but really it may help to make a difference. But I see one of the questions asked about social media and online activities. And from the partnership side of things, being able to come together, particularly at that time in the workshops, was really powerful and a great asset to have. And I still remember vividly with one of the early ones we had with community leaders. Mabrak, you'll probably picture one of the Muslim community representatives. And there she was sitting next to our cancer program lead. And he just said at the break time, "Can I ask you about these national leaflets and the language?" And she was happy to do that. And actually there was changes, and that was fed back up to NHS England. So that was an additional benefit from part of that activity. But it takes time to sort of develop and understand. There are, lots of challenges, but it's having that working relationship of being able to sort of pick up the phone, discuss, and also the committed interest and drive between the different partners. And as Mabrak said, the voluntary sector are so key to NHS and health and care sort of working across our system. And certainly in East Sussex, we have an East Sussex Commissioning Excellence programme working with the VCSE as a partner along with our local authority. And we're sort of halfway through that programme. And that's really helped to sort of where we've had, difficult conversations to take place, but we've got the established relationship and the confidence in each other to have discussion about these sort of things, and how, well, this has come up and how do we work through that. So, you know, very grateful to all the sort of partnerships involved and having Health Watch involved earlier on in this from the voluntary sectors, a lead in. And then, you know, also being able to take, there's the front facing, which is MEBRAC and the delivery and the experience and seeing the training grow, but it's how we can also support that and share it and share that good practice and encourage it across our health and care system. And also thinking about, you know, with our integrated care teams that many other ICBs are developing and working on, you know, it's how we develop that sort of culture and way of working to sort of have better understanding and insight into our communities and how best to communicate with them. And there's nothing like having that direct insight. Really is very powerful. I could say a lot more, but I'll pause here.
Thanks. Yeah, I think you made some very interesting points around the demystifying partnership working bit, which is around taking time, working on building relationships, because that helps with difficult conversations, and working with communities and the role that DRI plays in the front end and what needs to happen in the back end. So thank you. Amara, do you want to come in and ask us a few questions which have come in the box, and also if you have any questions? Yeah.
Yeah, of course. First, I just want to say thank you so much to all of our speakers. Some really inspiring learning. So thank you for taking the time out to share that with us. The first question that kind of came to mind, I feel like was mentioned in Sonaxi's presentation and also MEBRAC's, but I was just wondering a little bit more about power and how within partnership working we can meaningfully explore and engage power and how it shows up. If anyone has anything they'd like to contribute to that, feel free to just step in.
I can. MEBRAC, do you want to say anything first?
No, you say something first.
Okay. Okay, so that's a really great question, because, you know, with right from the start with the application, you know, we had to take it and have approval at senior leadership so that they are aware of what we're doing, how that links in with our sort of focus as an organisation, and the appropriate sort of use of officer time if it isn't financial resources. So that's really important, and that's cemented right at the beginning of that piece of work. And then, but it's also keeping that live throughout and understanding what our governance processes are. So it's taking updates on this work, how that's shared, and sort of, so for example, in East Sussex, we now have an East Sussex Health Outcomes Improvement and Oversight Board. So this work was then shared by the Chief Executive Officer for East Sussex, and then, you know, subsequently again shared across Sussex in our Chief Exec's report earlier this year. So we have that sharing of information, which also gives that sort of support and interest across our system about how we look at that. Certainly from a primary care, we have, you know, different sort of relationships. So it's working supportively with our GP practices, encouraging the uptake. And recently we had a discussion because MEBRAC's been really great at exploring tailoring this training course with different audiences. And certainly when we worked with receptionists in primary care, that was really helpful as front door and being able to sort of support the people within the practice as well. So I think it's there's lots of different power balances at different stages and different places as well. And it's understanding the dynamics, and some of those things that experienced people like MEBRAC, you know, are so familiar with, but they're not to be sort of taken for granted, because they're really, really important about knowing where and who and how to share information with to help continue that support and profile of that work as well.
Thanks.
Yeah, I think in addition to that, there will be always imbalance of power. Mm-hmm. That is there. But I think the real power is within the communities and the partnership. So you just have to go beyond that and push for that. A kind of, oh, the NHS is much, much powerful than the RI. There is no question about that. But you have to work with the organization, because in the end of the day, NHS is our NHS. The NHS is looking after the health of the population, and the power is within the people. It's just how do you make it work is the important thing, and you just have to push on. You have to keep going. You have to make sure that things is followed up. So yeah, I think one of the things that gave this a balance of power is having Amanda and Kay, which they reach the leadership of the Sussex NHS quite easily, and we reach the communities. So that balance have to be there. And DRI is a very small ethnic minority-led organization, but we work very well, and we push to work very well, and we learn from the big organizations such as NHS, and they learn from us. So I think we need to believe the higher power, to me, relies within the communities, and the community organization need to be empowered to stand for the communities. And the NHS, in the end of the day, is our NHS. It's the NHS that looking after our health, so we need to look after it, but it needs to look after us as well. Thank you.
I'll just add to what Miprak was sharing. I think it is about having those cross-sector collaborative champions working together. So as she was saying, Amanda from the primary care network, Kay at the NHS, possibly someone at councils and different areas as well, working together helps balance out that power imbalance, because you're speaking on the behalf. The ones who've got the power are speaking on the behalf of the ones who don't. That's one way of how you can demystify power in partnership working. The other thing that we encourage at our workshops is to keep ego outside the door. So when the people come into the workshops, don't come in with your badges of your organizations. Come in with just your name and ready to engage sort of a way. And our starting point of trying to balance out the power a little bit is to keep roles a little bit further away and organizations when you're coming into a space for having those collaborative conversations. That's what I would just add.
Yeah, thank you everyone for your contributions to that question. I'm conscious that we've actually got a few in the Q&A, so I'm going to move on to them if that's okay. The first one that we've got is from Adrian, who has asked if the panel has found the use of social media and online events or activities useful, or if there's a preference or better engagement with face-to-face approaches. Mabrak, maybe that's a good one for you.
Probably I have been around, I've been working in Sussex for the last 25 years. My way is face-to-face. The online is good, the social media is good, but if you really want to develop relationships, then, I think face-to-face works for me. Face-to-face is much powerful within the community that I work, but that doesn't mean that social media and online, thing is, it's not doing well. I think in particular for those, communities who struggle with understanding the UK system, the culture, the language, face-to-face works much, much better in engaging with them. And as a policy, DRI, if we can have the resources and the time, we do it face-to-face. And it's working much, you have to understand, how did these people come? What is their behavior? What's their tradition? What's their culture? And face-to-face, the human connection and the human empowering each other works much better than just having a Zoom for 1 hour and then, and go. I think it's good, but the human connection, building relationships, building confidence is in the face-to-face. That's me.
I agree with that. The way we work through our Connecting Health Communities is most of our community-oriented workshops happen face-to-face, and we kind of have that as a part of when people sign up to be a part of the work, we ask for people to commit time face to face, because as Babrak was saying, and I think Kay mentioned the space to have difficult conversations. Having those difficult conversations face to face is sometimes easier and much easier to sort out as well, and think of what can be done to make things better when it is face to face and it is online. So yeah, that would be my perspective as well.
Thank you both for coming in on that one. I'm going to move on now to Lucy's question, who has picked up on something that you said, Mabrak, about removing barriers around budget and time. And they were interested in knowing more about what that's looked like practically. So Kay or Mabrak, if you'd like to respond to that, please feel free.
Mabrak, shall I let you go first and then I'll follow?
Okay, it's my turn. I will answer this from my own experience. Myself and Dr. Ya set up this, community interest organization in 2004, following the Iraq War, just to support the young people who came from, Africa, Middle East, and all walks, of the planet. And Hestin was a dispersal area. And we see a young, predominantly men, walking aimlessly in Hestin, and we thought, well, let's set up this befriending scheme so that the local community would support those, one-to-one. And this is how DRI started to work. From day one, the challenge we have is time and budget. It's like you get £5,000 from somewhere, and once that £5,000 is gone, it's like turning off the water. So, but you find, and I think, to me, how is that? How is it even perceived that you make a difference within £5,000 for 6 months? What does it mean? How is the continuity, considered with this? So throughout until today, if you ask me, the challenge we have is there is no budget. And also, we don't have the capacity in going through the big lottery fund, for 3 to 5 years. I don't know myself how to apply for. I don't have the language of funding, and I don't think I still have them. So I think that support financially it has been, and it's still a barrier for us as a small, social enterprise community interest organization. Time, well, we work weekends, we work, Friday afternoons. We give 10% of our income. How many in 2006 or 7, there were 27, ethnic minority-led organizations in East Sussex. One by one, they've gone because people cannot, they cannot cultivate that, organization and live in their families. And so in the end, what we decide is, working both full-time, we decided, okay, as a policy, anyone involved with DRI, they have to give 10% of the training or the consultancy, whatever they do. And then on the top of that, we get little funding. So how did we come? How did we survive 20 years? It's going to be 20 years in 2000, from 2004. We manage the finance so well. And also, we start to connect to so many organizations. For example, this working group is funded 2,000-3,000, but that covers, that removes the barrier of transportation. And then, we encourage the Sussex, active Sussex, to keep going with that. It's so important. And I guess at some point, the NHS, that is removing, if people look after themselves by walking, it's removing a lot of health problems, including mental health, stress, losing weight, diabetics. You call it how people can look after themselves by a little support. So we are encouraging universities, research institutions to have evidence. And also we asking research institutions to share data with us, so we can learn how to put these data when we apply for funding. So I think we're getting a bit smarter, if I may say that, and we are demanding, for example, I always ask for Sussex, medical schools, we work with you, but share the data with us. So when you share the data with us, then we can make a claim with evidence, so we can get funding from different organizations. But it is very hard. It's really, really hard unless you have your heart, in this, and you have really, really the stamina to keep going. I hope I answered it, but this is just my experience.
And so thank you for that, Mubrak. And also I think the whole funding world across our health and care system has changed quite dramatically within that time period as well. And I have to say the voluntary sector shows great ingenuity around being able to source funding in different ways that maybe our sort of NHS and social care sectors, differ. But also we work closely with those communities as well. So, for example, public health will support Active Sussex through the Healthy Weight Group and other sort of links and routes of funding that might come to us centrally as well. But we also have, so whilst there, those very real challenges that Mubrak has as well there in NHS Sussex, we do provide a service around the translation interpretation, but that's a different service to what Mubrak is talking about in addition to this. But now we have, GP practices are in a position with budget to be able to then look at sort of taking, choose which training they wish to have. And it's how we then work together collaboratively to promote, to share that and make it sort of appealing for them, and sort of helping their processes and their communication and engagement with different communities in a way that they maybe not had before. But also I've been at other meetings in the past and I always said, well, if the NHS doesn't have the funding or the budget for something, it's great to be able to discuss with them, because also they have other routes or insights or access or applications that they can make that maybe we are excluded from. So again, that partnership working is really, really helpful. And I think we've got with the Sussex Voluntary VCSE Alliance that we have, that's there to support and work with different sort of voluntary and sector community providers to be able to sort of help navigate those areas as well. But it is a complicated process, and it is a challenging climate. So I think it's really excellent that we do have strong foundations from which to build on, and how best we focus with this sustainability of this work.
Can I add one thing as well?
Yes, sure.
I think another thing that I would share and recommend is, when you are trying to spend your time, select where. For example, I choose to be a trustee at Sussex Community Foundation simply because I want to influence. And as a result, we have training for small organizations, including ethnic minority-led organizations, and how to learn the language of funding. So by being part of board of directors, board of trustees, you really can influence change. So if you are a leader of an organization or voluntary sector or whatever, select where you want to sit, where you want to spend your time, and then genuinely work to improve the inclusiveness of that organization in everywhere that the organization goes. It needs to think of, is my organization inclusive? So I would say, and when I say, we're getting smarter, we select our time. Where do we invest this time? Unpaid, but while we're doing it, it has to be in the right place, in the right influence, not just for your organization, but for everyone.
Thank you, Mubrak. Just in the essence of time, because we only have 5 minutes, and I feel like we could just continue this webinar all day, but the weather is slightly too good for that. I'm just going to try to combine the final two questions that we have in the Q&A. Sonakshi's really kindly responded to some of them as well in text format. So to just kind of, I guess, end on Samantha and Alistair's questions, just curious if you have any reflections on how you'd like to build on your work and developing relationships with communities and public sector colleagues in the wider system, and or any thoughts or reflections on balancing evidence solutions as opposed to joint feelings about the work that you're doing as well. So feel free to respond to both or either.
Okay, over to you.
So, because this is for a reasonably short period of work, so it would be considered as being a pilot to give us some information. I think it's really good points to make, because we are asked to be focusing on outcomes and how we capture those. So certainly some of the outcomes that we're wanting to capture for this are much more longer term, and it is quite tricky in the sense of, so we knew that there was a lower uptake in cancer screening amongst cultural and ethnically diverse communities in the Eastbourne area. But until we sort of follow up in a year or 2 years, we're not really going to know what impact that has had. So that's a challenge. But I think we get feedback from the training, that information's collected, but also then it's having that local knowledge and engagement with the practitioners involved or the clinicians involved there, and their feedback on their experience of the course, and and how that has made them feel and think about and reflect on the work that they're taking forward, and also seeing change in sort of culture and way of working at a local level. And also through people like Mabrak and her colleagues, through the connections through community groups, it's that experience of feedback as well. A bit like we'll capture with carers as well. It's what's the voices of those individuals and hearing them. It's not a specific set of KPIs that we can use in that way, but it's how we have that qualitative insight. And again, as many colleagues here on the call will have, when we're forming projects, we have now, project briefs. We're saying, what are we going to be looking at? What are we looking at the end of this? What is the anticipation, the impact of it that we'd like to see? And these things have to be signed off nowadays. So that goes through what would be our internal governance processes. So this was a really exploratory piece, and the timing was fantastic after COVID. And one of the things that I really liked about it was looking at from our population up, rather than from a sort of top down from an NHS England or a directive of what our requirements are. But it gave us a real opportunity after COVID to listen and hear feedback there. So that was really, really key. So to answer your question, yes, we have captured and reported around the feedback, but to give specific KPIs at this stage, we need to do it over a period of time and about certain processes in place. And it is about tracking that and having people like Mabrak that have been in our local system being able to report and see those changes along with other colleagues as well.
Thank you, Kay. I think that's a really good note to finish on. I'm conscious of time, so I'm just going to hand over to Sonakshi to conclude today's webinar.
Thanks, Amara. I think just like quickly just say on the point that the whole focus of doing this work was around building a case for doing partnership working. And I think our focus was around building better partnerships, and the focus of connecting health is in areas is to do just that. And I just wanted to say that if you wanted to apply to be a part of one of the areas of our phase 3, I've put the link in the chat. Definitely do apply and get in touch with us if you have any other questions. I think there was one question by Claire that we haven't picked up in today's conversation. I'll follow up with you, Claire, on email. Thank you so much, Kay. Thank you so much, Mabrak, for joining us and sharing your thoughts. Really appreciate it. And thank you so much, everyone, for joining us today. Thank you.